Hello, anyone have any questions? Okay.
That means that they understand
excuse me.
everything or they don't understand anything.
Just, I'm Kosa Dube. I call from Cote d'Ivoire. I would like to know the difference between microwave and frequency machine.
Radio
I want to
frequency,
know the
difference
advantage.
between microwave and radio frequency.
Yes, exactly. Thank you so much.
They are both heat ablation procedures. The same indications and contraindications are the same. In radio frequency, the microwave. The main advantage I said with microwave is that there is less heat sink effect. So it's safe or effective in lesions beside major blood vessels. Major blood vessels, major hepatic veins, or portal vein branches, which causes cooling during RFA waves. This is not seen or extremely less seen during microwave ablation. Microwave ablates more areas in a less time. So if I have a patient with, as we said, the anesthesia doctor is very afraid of him, doesn't want to give him a large anesthesia time, and I want a rapid technique, I think microwave is better. But the same indication the same. They cannot be used beside direct bile ducts or bowel loops. And this, I think, the availability and cost and the personal preference may guide you. If I have, I think, for me, if I have both in the same setting, microwave and RFA, and both can be used, I go for the easiest and cost-effective for the patient. Especially in our country, most of our patients are not insured and they pay for the procedure upon themselves. So recently or lately, the microwave machines became comparable to radio frequency, nearly comparable in price. So I shifted my practice now to microwave. A lot of cases done by microwave. Before, the distributor was very priceless, and there was a great difference. The microwave costed 3 times as the radio frequency need. Now I think no, they are nearly the same, slightly over with the microwave, but microwave the ablation zone is better, more and faster, especially in large lesions and all the patients. The microwave is better. Yes, radio frequency is the standard protocol. So I think that if I have a very small lesion and I can do it safely, radio frequency and microwave are the same. Large lesions are for microwave, lesion beside the blood vessel beside microwave. If I have a lesion beside a major structure and I'm afraid to ablate it, no, use radio frequency, because the microwave heat production is more aggressive than RFA. So if I'm afraid of a bile duct and the patient cannot do taste because the liver function is not so good, patient preparing for transplantation, patient has a 1.5 centimeter lesion, and the patient is preparing for transplantation. So I cannot do taste for this patient because he is child C. And I'm doing this as a bridge for transplantation to give him time to find the donor and be ready. So I can use radio frequency in this case, a small lesion, to avoid injury of a large zone that we will make liver decompensation or bowel injury. I hope the answer is clear. And if you have any other issues to ask, please don't hesitate.
Please, can I have? Please, can I have a question?
Yes.
Please, I am Zaid IR from Iraq. Thank you for your nice presentation, sir. 5 centimeter metastatic, single metastatic breast carcinoma in the liver, near the hepatic vein confluence into the IVC, just subdiaphragmatic. What you prefer in this case?
It's a difficult question, but I prefer indeed this lesion. If if surgical is not option, and usually breast cancer patients, to find a breast cancer patient with liver only disease, it's extremely rare, in our practice, at least in Egypt. But if I'm going to, they want me to treat this, I will do a combined embolization and microwave ablation. Combined, I go from the catheter to
It is
inject
hypovascular on angiograph. Hypovascular lesion.
In CT, hypovascular on CT, or you did angiography? No, do angiography.
Even on angiography, hypovascular.
Hypovascular. Okay, ablate with microwave. I do blunt embolization. In these cases, I go to the segment and do combine CT, and it will have, yes, it's not so hypovascular as it seems. Sometimes hypovascular on CT, but when I do an angiography, I find a vessel. I can embolize it using spheres, no chemo embolization, no lipidol, only spheres, microparticles, very small, 100, 300 particles, embospheres or PVA, very small particles to embolize the feeder, and then I will ablate maybe in the same session the tumor. We're using the microwave as long as it has a good access for me on ultrasound. I can have a good access and see the lesion. Yes, diaphragmatic, we can see it good with some tricks and some. Sometimes I make the doctor of anesthesia to produce positive pressure to lower the diaphragm to see the lesion better. There are some things to do. I will ablate with microwave and embolize if it's hypovascular and I don't have this and I cannot go to the tumor. I will ablate only with microwave and see. Microwave, good technique. Give him a large power and good time, 15 minutes, 100 watts, and I think it will be good.
Sir, if after 1 month on follow-up there is still residual active part of the mass, it can be repeated at this time?
Yes. If you can differentiate it in the ultrasound, for me, there is contrast ultrasound, but we don't have it in Egypt on commercial basis, contrast ultrasound. But if you can discriminate with ultrasound the lesion, the ablated from non-ablated lesion, yes, I do. In colorectal, in HCC, as long I can discriminate it with the non-ablated area from the ablated area. They usually have a different echogenicity on ultrasound, so I direct put the needle inside the non-ablated area or non-treated area. Yes, we do it after case.
Please, can I ask another?
Yes.
What type of anesthesia you usually use?
Usually I use anesthesia, deep sedation. We have anesthesia doctor with us. He gives him, usually he puts a laryngeal mask with spontaneous breathing, but doesn't put an endotracheal tube. But anesthesia, we give him Diprivan, propofol, and then gives them a laryngeal mask with isoflurane. Yes, yes. Some use conscious sedation. No, I don't use it in ablation. Our patients in Egypt are very irritable. I cannot use conscious sedation. I can use conscious sedation in thyroid ablation. Thyroid ablation, I use conscious sedation because I want him to talk with me, because to hear her voice. But in liver ablation, I do anesthesia, not deep anesthesia, but anesthesia to take my time during ablation. I don't like to do a rapid procedure and make the patient go home. No, I take my time in ablation, take overlap, don't like to rush. Then you are doing a procedure in ablation comparable to hepatectomy. So this is a very important procedure. You are taking a malignant tumor, especially a malignant lesion. So you must take your time and let the patient shut up and do your procedure.
Please, if the vein, a hepatic vein or a branch of portal vein, major branch of portal vein in the field of microwave ablation.
In the field when you're going inside. the track,
in the
or the
tract,
field of
yeah.
ablation, in the track.
Yeah,
Yes.
it is. Yeah, it is. It should be transverse during
Do
needle
it. No problem.
infusion.
No problem. No problem. I do it.
No problem.
I do it. As long, yes. Try not to go inside. The advantage of microwave probes now that is, I think it's more rigid than before. Before it was very flexible and not good. Now it's good. So I can ablate. I can, when I'm going inside, and if I have a major vessel, I can shift my hand up or down for a couple of millimeters and then redirect my hand to go in the center of the lesion. And if I accidentally transfixed a hepatic vein portal, no problem. And even when I go my track ablation, track ablate as you go, it will not have do anything. It was recorded in some cases, lesion beside major hepatic veins, like the confluence between the two middle and left hepatic veins here. If I have a lesion here, I can produce mild thrombosis, venous thrombosis, usually transient and resolve spontaneous. It doesn't need anticoagulation, doesn't need anything, and doesn't mean any vascular invasion or anything, as long it was intact before you ablate, and you find it in the early follow-up. Usually it goes by without any intervention afterwards.
And if the vein is within the field of ablation, what will happen?
No, nothing. I didn't have any case of bleeding. No bleeding. No, don't worry. No problem. Ablate, yani transfix. I mean, when to transfix, when the track transfix it, no problem.
Yeah.
Try to avoid, but if you can't, if not unavoidable, no problem.
Yeah. Thank you, sir. Thank you.
Thank you.
Professor, I have one question. You mentioned about moving the antenna tip inside the lesion when answering the last question. So I have a question about the liver cirrhosis. We had some feedback from some of the doctors that when they are doing ablation on the tumor, which also has liver cirrhosis, they felt difficulty when they're trying to adjust the antenna tip. So have you ever came across with this kind of problem?
Yes, this is our daily practice. All our patients, or most of our patients, are cirrhotics. This is some cirrhotics are more cirrhotic than others, and some there are very, very difficult lesions. Even patients with Budd-Chiari disease, sometimes they develop HCC. And their liver is very, very tough. The most tough liver you can find, the Budd-Chiari, congested, extremely congested liver. So yes, we can find some. Try when you see have a tough liver, when you enter and you see it's very tough, try to decrease your track. Make it as short as you can. Go from beside, from behind. Start to make the track at least as possible, because when you are going, you can see the needle and the lesion in the same plane, and you theoretically go down and you'll be inside. No, when you go down, the tough liver makes you go up and down and right and left. So try to minimize the track length, and indeed the needle of the manufacturer will differ. Indeed, these patients, smaller needles, sharp needles are needed, and I think most of them are sharp now, very sharp needles to cut and go inside good.
Okay, thank you very much. So would you recommend, in case, let's say, we could not find a very easy way to go into the cirrhosis, so would you recommend taking the antenna out and puncturing one more time?
Yes. And it happens a lot. I go inside and I cannot, I will not reach this length. So I try to, I can ablate the tract or not according to the liver condition of the patient. I usually don't needles are small size, nothing will happen. But I prefer to find a shorter track, and if I cannot, sometimes I didn't abort a patient, a case for something like that, but I do with the best I can. Overlap, take it overlap many times to achieve as much as I can good ablation.
Okay, good to know. Thank you very much. And since we're talking about the track ablation, I have another question about the track. So do you do track ablation for all the liver ablations? And if yes, what is the power and time setting normally?
Yes, we do. Yes, I think all ablations are to be track ablation. I ablate till the liver capsule. I ablate usually under ultrasound guided.
Okay.
To see the ablation track. Avoid ablating of the subcutaneous tissue and the skin. Sometimes, when I enter and there is a spurter in the skin or subcutaneous continuously oozing, I ablate this area. No problem. Very small shot will not do anything.
Okay.
That I think the power will be 40 or 50. 40 or 50. And every 5 seconds, I withdraw 1 centimeter. 5 seconds, 1 centimeter every 5 seconds.
5 seconds, 1 centimeter. Okay. Okay. Because this seems a little higher, the power seems a little higher than what we normally recommend. And is it safe enough? Because sometimes we were worried it may burn the patient when we're pulling them out.
No. If according, I sometimes even I sometimes even withdraw on the power I am using during microwave.
Okay.
But I don't wait for 5 seconds, only 2 or 3 seconds.
Right.
Sometimes I'm on 80 or 60, and then the last I'm doing a couple of sessions for the same tumor, and I'm satisfied with the result. So I tell the guy of the company with me or that I will now ablate. I will not withdraw. You told me I will lower the power. No, don't lower it. I withdraw. And even on 80 for a couple of seconds, nothing. We didn't find any problems from the track. The problems we experienced in the first cases, of our experience was the shaft overheating. Now we don't see it but we saw it in a couple of cases, 2 cases. I think not your machine, but another machine. But they told us we don't have a water heating procedure, cooling technique. We are internally cooled something I didn't understand and didn't work, I think.
Okay, understand. Yeah, thank you, Professor. So it's other doctor any question?
Yes, please. If we decide to repeat the ablation time at the same session, how and it is under ultrasound guide, and but the air inside the lesion is a problem. How we localize again?
Yes, that's a nice question. See, if I'm planning to do a multiple ablation, sometimes I plan to do multiple ablation. I see that this lesion, I will ablate the superior aspect first, then I will go down and put a superior. This is planned from before the technique. That's an issue. So I withdraw and wait a little bit. Wait 5 minutes, no problem. Wait 5 minutes to the air the fire to go down, and then I usually withdraw the needle 2 or 3 centimeters, ablate the track, and reposition my needle. Sometimes it appears during the procedure that I see an area not satisfied. I'm not satisfied with this lateral area or like this. So I ablate, and then go out with track ablation. I can do track ablation, then reposition my needle, wait for a couple of minutes, no problem, and then re-enter. waiting makes there's another issue. Sometimes you can put the needle, and during the ablation procedure, you see an area it is not ablated. Then you go to this area. You see another area not ablated. This is shadowing from the air. So don't rush and say this is not ablated. No. Wait. After this, then you find it ablated all the area. So during ablation, you can misdiagnose areas not ablated, but they are actually shadowing from the air during ablation. So then try always to wait until the procedure finishes. Wait a couple of minutes before you decide to abort and end the treatment session.
There is a limit for the number of ablations on the same tumor?
No. I don't think you will three ablation or four. I never did more than this in a single lesion. Especially, I said microwave, the production is very, very strong. Don't underestimate. Sometimes when you over ablate, you get complications. And sometimes you see a lesion, 4 centimeter lesion. I ablate 2 or 3 times. In the follow-up CT, you see a very large ablation zone. Don't over ablate, because that means a complication. And I usually, in our practice, we give usually antibiotics after the procedure, antibiotics and analgesics after the procedure.
And before prophylactic antibiotic?
After we give antibiotic after the procedure for 5 days, cefotriaxone for 5 days, intramuscular.
Thanks, sir. Thanks very much.
Thank you.
Okay, it seems like Dr. Tawfiq has a question. Dr. Tawfiq,
Yeah.
Okay.
Yes. Nice. Assalamu alaikum, Dr. Mohammed. How are you? It's a pleasure to see you as always. I have a couple of questions, please. If you have subcapsular lesion and it is subjected to sometimes in cases we see rupture, how do you recommend to avoid the rupture of the subcapsular lesion? And if it happens, what will happen during this? Another thing, did you think that if in some cases that we can put like multiple needles before doing the ablation with maybe bizarre shape lesion or big volume lesion? The last thing is about the axis. Did you think if we could do like coaxial needle that could make it easier to get the axis, and this axis is predetermined, and we can use it multiple times? What do you think about these 3? And thank you for sharing your experience for sure.
Thank you, Dr. Tawfiq. A subcapsular lesion, as we said, we tried not to puncture the tumor directly. We tried to puncture through a liver window, not to puncture the tumor directly. Sometimes we had a lot of cases of bleeding. Not, I think, rupture, we call bleeding from subcapsular lesion. Usually they are managed conservatively with plasma, vitamin K, medical management. I had a patient transferred once to ICU from something like this. One of our professors, Dr. Ahmed, had a case of intercostal artery bleeding.
Oh.
After we finished the procedure, the patient was bleeding. We can see intraperitoneal. We go for angiography. We could not find anything bleeding from the HCC, from the hepatic artery. And during, we found intercostal artery and was embolized and was saved, the patient. So intercostal artery bleeding may happen. Everything may happen during bleeding. But usually managed conservatively. If the patient continues, we go to the angio room. Rarely we go to the surgery. We can go for surgery if they are available and ready. But we do first go to the angio room and try to seal the bleeding. The second question, multiple needles in bizarre or huge lesions. I didn't try something like this. I do a microwave or ablation in general for well-defined lesions. well-defined, well-encapsulated lesions. Bizarre shaped lesions or infiltrative lesions or not ill-defined lesions, I prefer to do transarterial therapy. And if I can control this lesion with transarterial therapy, either chemoembolization or radioembolization, and I have a residual that can be ablated, yes, in this case. Like from the first place, I didn't know, I don't have this experience. Coaxial needle, yes, we can use coaxial needle in case of we won't take a biopsy sometimes. It's said that coaxial needles decrease the incidence of tumor seedling. Yes, it does, I think so. But I think it's more sophisticated. Put a needle and then a needle inside the needle. No, why? And the biopsy. If I want to take a biopsy to prove something, or I don't want to puncture the tumor twice, okay, I use a coag. But this is extremely rare. Usually, we have our diagnosis before, and we don't have any genetic or research to take biopsy from HCC now till now. So no, I only do single needle and don't use coaxial in routine practice. No.
Okay. Thank you. Not all the doctors are has the same experience like you. So maybe somebody.
Yes, I can say yes, and
you know, it's a freehand technique, so we have differences in the expertise.
Yes.
So
if everyone wants to do his own, is accepting, I'm comfortable with this. Why to change?
Sure,
everyone resists change.
Okay, about the combined therapy, you know that we have 3 schools of combined therapy. I mean, if there is an ablation and also embolization before, after, in the same session, what do you usually recommend, and what are usually the indication for that?
Usually we do combined lesions for large lesions. Usually we do combined lesions for large lesions. This is the main indication of combination lesions, even now more than 3 to 5 centimeter lesions. So the standard, we do transarterial therapy first, and this is the more data on this case. Transarterial therapy first, and then we do the ablation after 1 month. Even sometimes I come to have a patient with a large lesion, 6 centimeter lesion, and well encapsulated. I put the combination therapy in my mind and wait. If I do a good taste technique and I'm satisfied with it,
thank you.
Yes.
Yeah.
Thank you.
Yes, and the follow-up, the lesion has become well embolized in lipidol, or if I embolize with beads or something like this, I wait more than 1 month to shrink more, and if it comes to a size that become after 6 centimeters become 4 or 3.5 or 4, then I ablate. Ablation, then transarterial therapy is usually in relatively smaller lesions. We do it, yes, but I think no, it's the standard or the better, embolize and then ablate.
Okay, thank you.
Thank you.
Thank you, Professor. I have another question, if that's okay.
Yes.
Yeah, I'm not a doctor. I'm just, I don't have medical background, but I'm a little curious about the hydrodissection part you mentioned. Some doctors, they mentioned they do the hydrodissection with saline water, but you mentioned glucose. So I was wondering what's the difference between...
No, hydrodissection, I think the aim of hydrodissection sometimes in thyroid, the aim of hydrodissection is to not to burn the skin or to protect the skin, but the aim of hydrodissection in colon, I think, is to push the away and not to ablate the colon. The colon wall is very, very thin. I use glucose because it is physically, I think so. I think that glucose doesn't conduct heat. saline conducts heat. Yes, we can use saline if I don't find the glucose, or the nurse gave me saline. I will not withdraw the saline. I will use it, no problem. But glucose is better in hydrosection in the colon, for it to move the colon away. If you want to put diaphragm, yes, you can use saline, because you are needing hydrosection to lower the diaphragm to make the lesion more visible and decrease complications, shoulder pain, and sympathetic pleural effusion. So I can use saline, use anything. But for the colon, because I'm afraid to make bowel perforation. So no, I prefer glucose.
Okay, thank you.
Thank you.
One last question from me, if that's okay.
Yes.
You shared one case, the patient, 62-year-old male with cardiac pacemaker. So you did ablation on that patient. So I was wondering, because a lot of doctors, they ask about this question, that if they can do the ablation on patients like this, and but there are not many papers indicating that it is okay or not okay to use. So what I'm concerned is there any special precautions that we need to aware of before doing ablation to these kind of patients?
No, I don't think there is. Most patients with pacemakers are usually anticoagulated or something like that. So you must control their anticoagulation. This is the main component. But microwave ablation is safe in patients with pacemakers. I think this patient, there was a debate on it. Some of the anesthesia doctors said, how we do microwave this up? No, I brought them and told them that this is on a non-electric current, so it can be done safely in patients with pacemaker. Even if RFA can be done in patients with pacemaker, can be done, but not so indicated. As long as the pacemaker is not in the circuit of the RF. You see, if the lesion here and the ground pads are on his thigh, so the circuit is between the liver and the ground pad. The microwave is here, the pacemaker is in his heart. It's away from the circuit. And I did a patient like this before, but I didn't realize that he had a pacemaker until we was on the table. He told me I have a pacemaker. Don't tell me now. So I made calls to some of our friends, and told me that. And the pacemaker is not in the field of the, if I'm bleeding a bone lesion in the humerus. This is contraindicated indeed. So, but the other patient with pacemaker is very, very safe to use microwave without any precautions regarding the procedure or the position of the tumor or in the left lobe. If it's in the left lobe, no problem at all.
Okay, that's very good to know, because
even I skipped the slide. There was a paper in the JVIR, the safety of microwave in patients with pacemaker. I skipped the slide. I passed it. I didn't highlight it good.
Okay. Thank you very much, Professor.